1 Theme Year Initiative of Pursuing Racial Justice at the University of Iowa. I'm Valerie Garr from the University of Iowa College of Nursing, and I'm your host for today's session where we will focus on barriers to health equity in Iowa City, centering diverse community voices. Our format today will start with introductions of our panelists, where each panelist will give a short presentation. This will be followed by my introduction of and commentary from Dr. Rima Fifi from the University of Iowa College of Public Health. Then we will have a questions and answers, the Q&A segment, where we will respond to the questions posed by our listening and viewing audience. If you are using Zoom, you can send a question to the panelists by clicking on the Q&A button at the bottom of your Zoom screen. Please note that we will hold your questions to answer them during the Q&A portion of this webinar. We know that health disparity or health inequity refers to a higher burden of illness, injury, disability, or mortality experienced by one group relative to another. This includes differences between groups in health insurance coverage, access to and use of care, and overall quality of care. Despite efforts by both global and local policymakers and health advocates to dismantle health disparities, persons of lower socioeconomic status, minoritized communities, and those who've experienced migration continue to have poorer health outcomes more than others. Our panelists today will speak of their experience in working to achieve health equity in Iowa City, sharing some of the issues they've faced, barriers they've encountered, successes they've achieved, and we will ultimately get to some possible solutions or improvements they would recommend. Let's meet our panelists. Adrian Silva is a medical interpreter and translator for the University of Iowa Hospital and Clinics and the Steed Family Children's Hospital. The UIHC Interpretation and Translation Services provides real-time interpretation by trained interpreters for patients with limited English skills and hearing impaired. Adrian was 8 years old when his family migrated from Mexico to the United States in 1995, moving to Inglewood, California. But it's over the last 10 years that Adrian has assisted in thousands of encounters with patients, families, and healthcare providers here at UIHC. He provides direct interpreting services both in clinics and inpatient units, helps train new interpreters, as well as helps to educate UI Health Sciences students and providers as to the best practices and ethics of using interpreting services. Welcome, Adrian. You need to unmute.
Thank you, Valerie, for that introduction, and welcome, everybody. I'm good. Everybody can hear me, I'm guessing, and I can't see, the attendees, but again, welcome and thank you, guys. And I want to spend just a few minutes with you guys talking a little bit about those issues that Valerie just brought up. I consider myself very privileged and honored to be in the role that I'm in, because I really feel that it is a unique perspective as to the issues with health disparities that many of our patients face. In my world, we're talking about limited English proficient patients, and many times immigrants and people that don't understand English well enough in order to have a good back and forth and a good communication with their healthcare providers. And so some of the things that we've seen, primarily obviously working in the hospital here in Iowa City at the University of Iowa, my role is to help interpret for patients both inpatient and outpatient, so clinics and hospitalized patients. And some of the barriers that come to mind just right off the bat, as you can imagine, is primarily the language barrier. Our patients need the assistance of an additional person, an interpreter, to have meaningful communications. And it's not always easy for them to acquire that interpreter, because language access is definitely a big issue for our patients. Even when we have institutions like ours that put some effort and really resources into having an interpreting services office within the institution, we still have to rely on additional services for these families, whether it's telephone interpreters or video interpreters and the like. And so the access to interpreters is a big barrier. And we have to also consider the fact that it's not just having somebody that can speak their language that they need. They need somebody that is trained and qualified in medical interpreting. So many of the patients that I work with sometimes have to rely on family members or community members to assist them with this interpreting, quote unquote interpreting, just because, like I said, it's, if they're not trained in it, then chances are what's happening a lot of times in these clinic rooms and in inpatient rooms is there's a lot of summarizing. There's a lot of situations where our families that are helping interpret for their loved ones, you know, they maybe don't have a strong fluency with the language. In my case, again, Spanish. You know, many of my patients will say things like, oh, my son is going to interpret for me, but they don't know how to tell me specific things, or they kind of just told me a little bit of what the doctor told me, but there's some things missing. That is a very real, you know, problem. It's a very real frustration and problem for our families, just because, you know, if they have to rely on somebody else to talk for them, you almost imagine that their words and their communication is not being conveyed directly. Their spirit, kind of their tone of the communication, those are things that end up lacking. And as a provider, it's hard for our providers to provide culturally sensitive and responsive care when the communication is not working, right? That's the main vehicle here for our families. And so, you know, we try to, and we'll talk a little bit about this, you know, later on as well, but what are we doing then to try to minimize those, you know, miscommunications and encounters with families and patients, so that we really give our families and our patients their voice, so that they feel comfortable, even if they're looking or meeting with staff members that don't speak their common language, that they are comfortable enough with an interpreter and trust the interpreter to have that, to be their voice. Because at the end of the day, that's what my job is on a daily basis. It's basically speaking for other people and stepping into other people's shoes, so that the providers can really hear directly from them what they need and what they're thinking, and, you know, how they're processing any sort of situation, whether it's medical diagnosis or treatment or post-treatment care, in all aspects of their care. That's one of the unique aspects of my job, right? It's really, I get to be one of the only people that provides that continuity of care for a lot of our families. You know, you can imagine if I meet a family at their first visit for an initial diagnosis, this person or family can be referred to many other providers within the same hospital. They'll go through many different tests, radiology, you know, blood, scans, all kinds of things. And in each of these encounters, our patients are meeting and talking to, you know, brand new faces, maybe people that they will never see again in their care. And it's really me and my team of interpreters, the ones that really get to follow them from start to finish, whether that's a good outcome at the end, or unfortunately many times also a bad outcome at the end. It's an honor to be in that role and have that responsibility with my patients. Some other kind of issues that go along with barriers of health equity really involve kind of the adverse effects that can happen when you don't have that initial tool that you really need, and that's a qualified interpreter. And so when we're relying, and patients are relying on their families, I mentioned a little bit ago, you know, they lose some of that communication, and that is a very real thing. Because just one example that comes to mind right away, I worked very closely with a family. It was a bilingual daughter, and her mom, who was in the hospital for some cancer treatment. And part of her treatment, she had gone through some clinical trials, because unfortunately, you know, the more traditional treatments were not necessarily working. And so they were going through some trials. And it came to the point where this woman was really declining, and they needed to involve palliative care. We needed to talk about hospice and all of that. Now, because they had a bilingual family member, you know, staff members were relying on her to interpret something the family member was not necessarily reluctant to do. You know, she was going to be the main caregiver, and so she took it upon herself to do that role. And that did a couple of things. You know, it puts her in a position where she is now both working as an interpreter and trying to provide support and be a caregiver for her mom. What ended up happening is the team came to talk to her and basically explain to the daughter that very difficult conversation that many of our families have, where, you know, that there's no real cure. We're talking about now transitioning to hospice. Now, this is happening in front of the sick woman. She's lying in bed as her daughter is talking to the doctor. And all of a sudden, I was called in because there was a miscommunication, and the daughter, requested an interpreter. When I showed up, we asked, after we figured out what kind of happened, the daughter explained to me that she really wanted somebody to kind of take over because she didn't know how to tell that. How do you tell your family, your mom, some terrible news like that? And the doctors really, when they called me, they said, Adrian, we really want to make sure that she is understanding. Now, when I showed up to the room, the first question we asked the patient herself was, what do you understand as of now happened? And her answer broke my heart, because she said, I don't know what they said to each other, but I can tell it was not good because my daughter left the room and she was crying. And when she came back, she was just more silent and, was not talking. At that point, the patient herself had no idea yet what was happening. Now, that scenario, and I'll add a little bit to it, but that scenario hopefully would never happen to a English-speaking, family, or somebody that could have direct communication with their team. That type of miscommunication hopefully would be avoided. But in this case, after we, talked to the patient, now we had that conversation directly with her, and the hospice, representative explained everything to her. And she was very attentive and with it. And the daughter at this point is now really there as a support person, a second set of ears, a second set of eyes, but she was not burdened with the heaviness of having to be an interpreter for her family. Now, the mom, the patient herself was so wonderful. And at the very end of this heartbreaking conversation, that there's really, at the end of the day for her, no hope for betterment. We asked, what does that make you think? What questions do you have? How can we, help you understand this? And she said, I don't have any questions. The thing she told the doctor was, that's after we talked about hospice. She said, that sounds wonderful. She says, I want to do that. That sounds like something that my mom could have benefited from, with her passing and her ongoing disease, years before. And so that showed me right away that's the way that communication should take place, because we allowed the person to have a voice. We allowed her to tell us how she felt. Her daughter was completely heartbroken and devastated that as soon as she shared the news, her mom was going to, be heartbroken and break down and deteriorate even faster, because she thought as soon as she hears that, she's not going to want to, eat or do the physical therapy or anything like that. It was, she was wrong. The doctors were wrong. Everybody was wrong, because the patient was grateful. She said she had lived a good life. She loved her kids. She loved her grandkids. She wishes that service was available for her loved ones that passed before. And so it was just scenarios like that can happen in our institution and in all institutions. And it's trying to remember that we want to provide authentic care for our patients, which means we need to be able to talk to them directly. We need to ask them from the beginning, do you want an interpreter? Do you want this person that's here with you to interpret? What do you want to do? We need to hear from them first. And so, if we can really provide good qualified team members to help these people communicate, it's going to be such a big difference for our families. And that's going to really start breaking down some of these health disparities, because that's just one of many. There's other situations that happen to our families or patients that don't have English as a way to communicate. You can imagine they end up having to be the ones that have delays in their care. They have to sometimes, and what I mean by that is, there's issues with miscommunications when they're doing prep for certain procedures. If anybody here has had the routine colonoscopies, or if you've had any type of procedure, there's some good prep and what medicines to take or not take the day before and things like that. And because of issues like that, when we don't communicate well with our families, they're more likely, non-English speakers are more likely to have to, reschedule or postpone or things like that. And so all of these things are institutionalized. We have to come up with ways to better work with non-English speakers so that some of these barriers that are gonna come up can start to be broken down, and a qualified interpreter can certainly help with that.
Thank you so much, Adrian. We look forward to, in the Q&A, learning much more about the things that you have brought up. Thank you.
Thank you, Valerie.
Our next panelist is the Reverend Dr. Joseph Lear. He is lead pastor at Resurrection Assembly of God in Iowa City. Pastor Lear grew up in Burkina Faso, a French-speaking West African nation. He holds a Master of Arts in Christian Ethics from Yale Divinity School and a PhD in Early Christian History from the University of Aberdeen in Scotland. Pastor Lear partners with immigrant and refugee populations in eastern Iowa. Welcome, Pastor Lear.
Hi there. Thanks for having me today. So just a little bit more about myself and my church to begin with. Resurrection Assembly of God is a church on the east side of Iowa City, made up of cultures, national origins, income levels, and age groups from across the spectrum. There was a Sunday not too long ago where we prayed in 15 different languages, and we did that with only about 75 people in the church. The New Testament says that after Jesus was raised from the dead, the early church had, quote, all things common. They shared their money, their possessions, their homes. They shared their lives with one another. This is something that we aim for at Resurrection Assembly, however imperfectly. And one of the ways that we have all things common is by advocating for one another in a world full of injustice. And that's what I want to talk about today, is advocacy. First, I want to talk about the importance of advocacy. And second, following from that, I want to talk about what I think advocacy looks like concretely. So first, the importance of advocacy. Now, in the academy, there's a common distinction between what is called quantitative and qualitative research. Quantitative research and qualitative research. Let me define those two words real quick, and I ask the academics in the Zoom room to forgive my overly simple distinction between these terms, but I want to define them solely for the point I'm trying to make about the importance of advocacy. Quantitative research is about statistics, using statistics that have been gathered by throwing the net wide to assess, define, and research on address a research problem. It's using numbers to create policy, law, and best practice. Qualitative research, on the other hand, is not so much about numbers as it is about individual stories. So case studies are used to assess, define, and address a research problem. Instead of looking at the group as a whole numerically, you dig deep into the stories of, for example, 3 minoritized families and their healthcare experiences in Iowa City. The problem that I think we so often face in the United States, generally speaking, is the privileging of statistics over stories. Don't get me wrong, I think and I know that statistics are very important, but the unique stories of individuals, families, and neighborhoods are so often compromised by the hegemony of numbers. People's stories need to be told and heard, and one of the ways that people's stories can be told and heard is by advocacy. People who know, who partner with, are friends with, who live in community with disadvantaged populations, to give them voice. The reality is that no amount of policy can do the work necessary that just some basic human decency can do. If we only have statistical models and policy, those in powerful and otherwise privileged positions can always claim that they are following policy, law, and all the company rules, and they can do that as they are all the while stepping on the necks of the poor. So, for example, I have seen over and over again landlords in Iowa City using the law and the police department to retaliate against their tenants for asking for better living conditions. I have a congregant who was moving out of their house because they discovered asbestos, among other things. This clearly upset the landlord because they were not only losing a tenant before the July-August lease season in Iowa City, but also because they were looking at major costs to get the house ready for a new person to move in. So the landlord surveilled the house for days on end, watching for one of the tenants' cars to be parked on the street for longer than Iowa City's 48-hour street parking limit, and then they called the police to tow it. I went over there as an advocate for my congregant when they saw their car being towed, and I confronted the police officer, explaining that she was being used as an unknowing tool in the oppression of the poor. But her response was, "I'm just following the rules." Now, I want to make this really explicit. Asbestos is a serious matter of public health, and this congregant was merely trying to protect their and their family's health. And what they got was the police acting as the retaliatory hand of a slumlord. We need more than rules. We need human decency and compassion. We need advocacy so people who don't have the time or attention of important people can have their stories heard. Now, of course, hearing people's stories doesn't guarantee that people with power and privilege will be compassionate, but I think it does make a difference. And that brings me to my second and related point. I wanted to describe what I think advocacy looks like concretely. Here's what it looks like. Advocacy looks like partnering with, being friends with, living in community with disadvantaged populations. Again, this is the kind of work that I do and my church does. Let me give you a few brief examples. One of my congregants, who is a Black male, was once an offender bender in downtown Iowa City. He was scared of the police. So while he was waiting for them to arrive, he called me to please come down and be with him. So I did. Another congregant was dealing with a landlord that was trying to extort her for money. And she was trying to, and I should say the landlord was trying to do it legally because there were rules that he was using for his extortion. I went with her and asked him to his face why he was stepping on the necks of the poor, whether out of intimidation or a newfound sense of human decency, he stopped extorting her. When I have congregants who need to go to immigration appointments for asylum, green cards, or citizenship vows in Kansas City, Des Moines, Omaha, or Chicago, I go with them. Or another member of our church goes with them to help ensure to the best of our ability everything goes smoothly. Now, when it comes to healthcare, we do the same thing. And this happens all the time. But let me give you just one brief example. I accompanied a Congolese friend and congregant to an appointment that was going to work toward a learning disability diagnosis for their child. The receptionist was outright racist to my friend. She was definitely following the rules because we got into the appointment and got help, but she was racist nonetheless. The doctor and some of the nurses were also a little condescending, but me being there meant that they were held accountable to help the child despite their lack of human decency. I was there as more than just a translator. I was there to translate from English into French and back again. But I was there as more than a translator. I was there as someone who could mediate between someone who was overwhelmed by life circumstances and a very powerful hospital system that sometimes doesn't treat people with dignity. I want to add that my associate pastor at our church here does very similar advocacy work, though with her particular skill sets. And with the same patient at the same clinic, she and an English as a second language congregant of ours will be met not just with condescension, but indifference and a total lack of patience. Her experience as a female advocate is entirely different from mine as a male advocate. Racism goes hand in hand with misogyny. Even my own wife, who has a PhD in nursing and is a white woman, oftentimes has me go with her to doctor's appointments because for some reason, if I but repeat the same questions she asks, more often than not, she gets better answers. So let me conclude with one recommendation about how I think advocacy can start. The number one way that I have learned to advocate for people in my church and people in the community more broadly is by visiting them in their homes. When you visit someone in their home, you get so much more context than a conversation in a sanitized examination room can get you. In people's homes, you can see all the underlying public health obstacles people are facing. So again, by way of examples, I know that something is probably amiss with one of my congregants' medications, or that they're struggling with addiction when I walk into their manufactured home and see over 50 pharmacy pill bottles sitting on the kitchen counter, all filled with a lot of pills. I know that sending a congregant who is a fall risk, sending them home with a walker isn't going to do much good because there's hardly a path to walk through in their home at all. Not to mention the fact that the carpet is ripping from not having been cleaned in the 20 years the person has lived there. I know how to check if a child's disability is the result of lead poisoning because I know the address of their apartment complex. I can check its construction dates and I can go inside to see if the paint is peeling off the walls. The associate pastor of our church, I've already mentioned her, she goes with women to doctor's appointments who have histories of sexual trauma, who otherwise just wouldn't go to the doctor at all, whether out of fear of a male doctor inspecting them or because they're afraid of a diagnosis. And she can do this because she's in their homes, which means she is in their lives, which means she is their friend and advocate way before the doctor's appointment begins. There are models in the Western world for in-home health visits. We do it for the elderly all the time. I lived in Scotland for 3 years, where doctors, nurses, and midwives come knocking on your door for health visits. If anyone would listen, I think that this would be one significant step we could take towards justice for all. So, in sum, just to recap, I think we need advocacy. And to put it as simply as I can, I think advocacy looks like friendship.
Wow, thank you so much, Pastor Lear. Our next panelist is Patrick Taggart. Patrick is a regional director of Proteus Incorporated, and he is based out of the Iowa City office. Proteus is an Iowa-based private nonprofit organization that has been serving migrant and seasonal farm workers, immigrants, and others since 1979. Proteus provides job training assistance with affordable healthcare and education resources to agricultural workers and their families across Iowa. Patrick has been with Proteus for almost 7 years. Welcome, Patrick.
Thank you, Valerie. I'm going to go ahead and share my screen, so it might take just a minute. And Valerie, if you'd let me know when you can see that, that would be wonderful. So I know that we're all on the same wonderful page here.
Absolutely.
Okay. We'll just sit here in awkward silence until that happens. Then I'm joking. As Valerie indicated, my name is Patrick Taggart. I am the regional director here in Iowa City.
We can see your slide.
All right, thank you. We also have offices in Fort Dodge and Des Moines. So we actually across the state we do the job training and healthcare provisions to the farm workers in Iowa. So just a real quick background on who Proteus is, and then I'll kind of get into some of the barriers we see with more of the focus on the healthcare aspect. Who Proteus is, our name comes from a Greek god. He was a sea god from the Greek times, and he would shift his shape in various forms to help those in need. So Proteus kind of takes that upon ourselves. That's what we do. We change our strategies, our methods to make sure that we're taking our services to those in need and providing the best care and aid that we can to them. So demographics. So what we do, again, focusing solely on the agriculture health aspect of things. What we do is we provide acute health care to agriculture workers in Iowa, to kind of sum it up. So that ranges from anyone born and raised here in Iowa. And then predominantly what we see on the healthcare side is the migrants and the H-2A workers. So those last two categories, the migrants, what we see here in Iowa predominantly come from the southern part of Texas. We do see from time to time some from Florida and Georgia, but typically what we're working with there are workers from Texas, and then the H-2A workers, which those are of course workers here that are on a short-term work visa. So what we see with the migrants is they're here from anywhere from 11 months to 12 months to as short as 3 weeks. More often than not, they're here for that time while the work's available, and then they return home to live out the rest of the year. Typically on the wages they earn here. Sometimes they get other jobs. But just kind of put it into reference on where we see it, and kind of where I'm coming from. This is the workers that come here for a short time and return home to their permanent place of residence. A quick overview of what our clinics look like. It's basically an urgent care on wheels. It's a mobile clinic. So again, we take our services to a place of preference, a place that makes it easier for the patients that we see. It kind of falls in line with what we just heard from Pastor Lear about the in-home visit. That kind of sparked my brain. So that's kind of what we're doing. So we're typically, some of the migrants come and they live in what we call the camps. They kind of live in apartment type, dorm type setting, or a big communal living. So we're there on site. So they literally come to our clinic and then can walk back to where they're staying for while they're here. So again, the services we provide are just the acute care. We have a pharmacy on hand that we can provide a lot of the pharmaceuticals they need, over the counter and prescriptions, and everything that we can't provide there on site, which is quite a bit that we can't provide because it's acute care only. So we refer those patients out to local organizations. So here in Iowa City, you know, we have a lot of agreements, and some of you might be out there listening right now, and we absolutely adore all of our partners, because without them we wouldn't be able to do it. But we send vouchers, you know, for those patients to go to, and that's where we run into a lot of the barriers, which I'll get into here shortly. So just kind of as an example of some of the vouchers we do work with is, you know, anything that's kind of on the list here: the OBGYN, the optometry, dental, and additional pharmaceuticals, radiology, things like that we just can't provide there on hand. So with that is where we get kind of more into the barriers we see. So I kind of have them listed out here. The number one thing we see is kind of the obvious, the no-brainer is the monetary and insurance issues. Just little to no funds and no insurance that they can you know, get that preventative or continued health care. But that doesn't matter for us. For us, we're going to see them regardless. But then when we do make those references to, you know, the optometry appointment, for instance, we can come in and kind of help pay some of this, if not all the funds. It just kind of depends on each individual patient what their needs are, but we can kind of help provide some monetary aid in that form. Transportation, as I mentioned, a lot of our workers here in the eastern part of Iowa, so a lot of our workers are actually in Williamsburg and in Conesville. The bulk of who we see are. We do have patients here in Iowa City we see pretty regular as well, but transportation becomes a big issue. Just we see, you know, we can help set the appointments up, but then they have issues getting to and from those appointments. Health education, I think this one is often overlooked, at least, again, the demographic we're working with. Just that you can see the unhealthy behaviors are often repeated, just because, you know, their surroundings that don't exactly maybe, you know, always not necessarily not approve of it, but it's a lot easier to live an unhealthy life with the work style they're doing. And sometimes it's just a lack of education. A story that sticks out to me, and it was 4 or 5 years ago, we're speaking with an older gentleman who was being seen for, I can't remember what he was being seen for, but we were talking about making better dietary habits. And you know, it was news to him. He was shocked to hear that drinking multiple cans of Mountain Dew a day was not a healthy thing. And you know, it's easier for us to kind of smile at that, but at the same time, he'd never been told that before in his life, to our knowledge anyway. And it's just, you know, it's just the importance of you know, providing that health education on what their healthy choices are for that specific example, but just on everything is kind of a barrier we run into. Fourth one, language. Obviously, Adrian already did a wonderful job. We're talking about the language and some of the examples that his story kind of spoke volume to. That was just all the things that can get lost in the translation there of, you know, just the broad overreach of, or broad over communication of what might be said, and just kind of things get lost. So just that language barrier is a big one. And then the last one that we kind of run into as well is the follow through. And again, this might be geared more specifically for the population we're serving, because they're only here for so long and then they return, as I mentioned. But what we see a lot, especially we work with a lot of diabetic patients, is just all the work we put in with them, and all the, you know, the health educations we give them, the medications we give them, the hey, eat this, not that situations. And then, you know, they start getting their life back on track and everything is getting back under control. Then they go back to Texas, they go back to Mexico. And when they come back in, you know, this time of the year, basically from here to May, they start showing back up, and we're checking their levels, and they're right back to where they started because they didn't follow that diet. For some reason, they couldn't get their meds refilled, which we do send them home with as many meds as we can. About 3 months supply usually is about the max we can. But again, it's just, you know, just that lack of follow through that we have that consistent and physical presence with them that we can provide. Again, that might be a little bit more geared towards the population we're serving because of the life that they're. That's kind of the quick recap of everything we have, and I think we'll take some questions at the end should you have any.
Thank you, Patrick. Our next panelist is Dr. Marius Ibuye Balola. He's a pharmacist, a Congolese community member, and a board member of the Congolese Health Partnership, which was established in 2017 and is a collaboration between Johnson County's Congolese community, the University of Iowa College of Public Health, and the University of Iowa Hospitals and Clinics. Marius attended Oregon State University, where he received a doctorate of pharmacy in 2019. Before moving to Iowa, he helped pass a law in Oregon that mandates pharmacies to provide medication labels in a patient's preferred language in an effort to remove language barriers. Welcome, Marius. Marius?
Thank you for that introduction. I am really excited to be here today and share the work that I'm not sure if everybody can hear me. Yeah, I'm happy to be able to share the information that the Congolese Health Partnership is doing here in Iowa to make sure that we are addressing the barriers that come in a way of accessing care. So right now we have been focusing on providing quality information. That means we are providing mostly information on COVID-19, and you want to make sure that the Congolese community in Iowa is understanding exactly what is happening in terms of accessing testing, in terms of accessing vaccination. We have been recording a lot of videos and post them online just to make sure that our community, since they have access to their phones, they can share these videos and be able to get quality information. However, what I am seeing as a Congolese community member as well is that we are able to give all this information. However, there's still more to be done because the community want to at least have the trust with the healthcare system that they are trying to access. Now, I'll share a story about Rafiki. Rafiki is a Congolese member who moved to Iowa recently, and through the checkup when they get to Iowa, the general checkup that they have to do to make sure the vaccinations are on track and all the healthcare needs are being taken care of when they first arrive here. They found that Rafiki has a heart problem and it needs a transplant right away. Now, this information has to be communicated to the family, and the only way to communicate to the family is to get an interpreter. Now, we do have an interpreter through iPad, virtual interpreter, and this interpreter is trying to tell Rafiki's family what is happening. The child has a heart condition, they need to transplant right away, and they don't have enough time to do that. But the family can't connect to what is happening. The family doesn't really understand if there is even a possibility to transplant a heart. And now they are thinking that maybe there's something that the hospital is trying to do to the child that they are not aware of. They feel like the hospital is trying to play God, and that becomes a problem. The family just say, we can't do that, stop, stop, stop. We don't even know what that means. Now, there is a disconnect from the culture standpoint with the interpreter and also the healthcare providers who are trying to help this family. Rafiki is running out of time. They need to do this surgery quickly, but the family can't connect. The next meeting, they invite again the family. Interpreter on iPad, they're trying to help the family, but there's no results. Second meeting, the doctor comes with the good news, saying we even have a donor, we can do this quickly. However, Rafiki's family is not connecting. It's still a problem. The child needs help. However, they can't get this help because there is a disconnection between the culture, the interpreter service that they are using, and everything else happening with being a new person, new to the United States. Now, the hospital think about one interpreter who is coming directly from Rafiki's community, and they involve that interpreter in the process. The interpreter come in with the knowledge of the culture, the interpreter come in with the knowledge of the faith that Rafiki family practices. And this changed the whole perspective. The language that the interpreter is using connects directly. They're still speaking same language with the previous interpreter, but just the lack of culture in this conversation is making everything worse. At this time, this new interpreter who connects with Rafiki's family now is able to explain the process, telling them that this is just what your kid will need to survive in the process. This is what your family will need in order to be able to see this person that you love again, applying the knowledge from the faith and also from culture perspective to help this person. We can see that, and at the end of this story, Rafiki's family was able to accept the care, and Rafiki was able to receive the transplant. However, due to the delay, there were complications that came with that. What I'm trying to say is that we are able to provide the information to the community, but we also have to build trust with these communities. That way they can be able to access the care that we want to provide. This means we can achieve this by only bringing the workforce that looks like the community that we're trying to serve. That means social worker, nurses who are taking care of these communities, especially the Congolese community, need to look a little bit like them. That meaning they have to at least have an understanding of the culture. They have to understand the language and be really able to connect with the patients instead of just saying, well, the Congolese community speak French, they speak Swahili, they speak Lingala. Now we just need to bring anybody who can speak that language. We have to be able to bring people from the community, hire them to make sure that they can be able to connect with the community when they're trying to access care. Now, we will ask, how can we get these people? There are people in the community who are well able to do the job, but they just need to have the training so they can get the paperwork that allows them to be able to work. We do have people who were doctors in the country, but they can't be doctors here in Iowa because of licensing and the time it takes to be able to transfer the licenses here. But those people, if they are well trained, instead of working in other areas, they can be able to work in the healthcare services and be able to provide care. And when people have people that connect with them in the healthcare system, they are able to trust that care and seek it when they need it. They can go to the hospital without having fear that maybe something else will be done to me other than what I'm trying to do here. They will know exactly that when I go in, they will take a good care of me and everything will be okay. So what I'm asking for people in healthcare, at least where the Congolese community are going, is to assess, do we really have the people who look like the community that we're trying to save? We need to avoid having numerical diversity and try to have really meaningful and impactful diversity in our workforce. And by numerical diversity, I'm just saying that when you need someone to provide quality care, don't just look at the numbers that you have in the people who are working. Say, oh, we have diversity. Well, we have someone who is in maintenance, that person increased diversity. We have someone who is a custodian, that person increased our diversity by number. But when we are looking at the impacts, do we have a social worker who represent this community? Do we have a physician who represent this community? Do we have a pharmacist who represent this community? That is impactful because those people can really change the results of this of the care that these people are receiving. And I'll be really happy to talk more about the solutions that we can bring forward in order to address diversity and health disparities in our community. And I'm looking forward to Q&A section, that way we can talk more about everything that is happening in order to address diversity and health disparities in Iowa City. Thank you.
Thank you so much, Marius. We'll definitely be looking forward to that in the Q&A. And joining our panelists, as I mentioned at the very beginning, is Dr. Rima Afifi, professor in the Department of Community and Behavioral Health at the University of Iowa College of Public Health. Her research and practice focus is on mental health, refugee and immigrant well-being, tobacco control, and intervention evaluation. She engages in public health research and practice with intent to promote social, community, and policy environments conducive to well-being. She applies community-engaged research and cultural humility to equalize power, voice, and self-determination of communities experiencing marginalization, and emphasizes knowledge transfer of research to practice and policy. Dr. Afifi teaches a variety of courses at the University of Iowa, including global health equity. She earned her Bachelor of Arts in Psychology from the University of Iowa, her Master's in Public Health from the University of North Carolina, Chapel Hill, and her PhD in Health Services Research from St. Louis University. Welcome, Rima. After hearing some of the things that our panelists have shared, I'm just curious if you have some insights about some of the things that you've heard, and what are your thoughts on some of the issues?
Thank you, Valerie, and thank you for leading us through this. Good afternoon, everybody, and I'm so glad that everybody has decided to join us. I do want to just, before I start my own remarks, appreciate all that has been said and all the stories that we have heard from Adrian, from Pastor Joseph, from Patrick, and from Marius. I think that the stories that they told really have uplifted the barriers to health equity in our communities. So just to say thank you. I'm going to focus my remark on 3 specific issues, and I did ask ahead of time for our panelists to share sort of their main points, and from those main points have sort of uplifted my own specific issues. But then after hearing them speak, today, I think many of the words that they used are echoed in what I'm going to say. Many of the principles that they have uplifted are echoed in what I have to say. So it's beautiful to see that synergy, I think. All right, so our session, our webinar today was called Barriers to Health Equity, Centering Diverse Voices. And I'm going to start with that first part. So what are the barriers to health equity? And so my first issue that I want to talk about is the structural and social determinants of health. So when we speak about health, many of us actually think ill health or think disease and automatically think about health care. You saw that and heard that a lot in the discussion so far already. But if we want to step back and think about a definition of health, it is quite broad. The World Health Organization defines health as a state of complete physical, mental, and social well-being, and not merely the absence of disease. Meaning that just because we don't have an identified health problem doesn't necessarily mean that we will be healthy. In fact, we know that about 20% of our health is related to access to healthcare, and maybe another 20% is related to biology and genetics. But that leaves a whopping 50 to 60% that's related to other factors in our environment, and you've heard some of them already. These factors are called social and structural determinants of health. The World Health Organization defines social determinants of health as the conditions in which people are born, grow, work, live, and age, and the wider set of forces and systems shaping the conditions of daily life. And I'll talk about that last part as well later. The Centers for Disease Control and Prevention organizes social determinants of health into 5 categories: economic stability, education access and quality, neighborhood and built environment, social and community context, and healthcare access and quality. So some of the examples of the social determinants of health would include safe housing, transportations, and neighborhoods. You've heard about those already. Racism, discrimination, and violence. You also heard that through the stories that were told. Education, job opportunities, and income. Access to nutritious foods and physical activity opportunities. Polluted air and water. Language and literacy skills, and many others. Recent analyses in the United States of America has indicated significant differences, for example, in life expectancy. So this is like birth and death, right? Death, in fact, and other health outcomes between adjacent zip codes. So life expectancy can actually differ by up to 25 years among adjacent neighborhoods. I have not seen this analysis yet done for Iowa or Iowa City, Coralville, Des Moines, but I'm sure that we would find the same types of results. And this has led to a recent slogan that your zip code matters more than your genetic code. So back to that definition of the social determinants of health, the conditions in which people are born, grow, work, live, and age. Place matters. The WHO Commission on the Social Determinants of Health ended their report with a statement that social injustice is killing people on a grand scale. They made 3 recommendations to tackle the social determinants of health and move towards health equity. And I think these can inform our work and our commitment to health equity. The first was to improve the conditions of daily life, the circumstances in which people are born, grow, live, work, and age. The second was to tackle the inequitable distribution of power, money, and resources, the structural drivers of those conditions of daily life. And the last one was to actually measure the problem, both I would say quantitatively and qualitatively, to Pastor Joseph's point. Evaluate action, expand the knowledge base, and develop an understanding amongst all of us of the social determinants of health. So our goal to decrease inequities and improve well-being must be to create environments where everybody has the opportunity to thrive. And those environments occur within the healthcare system, but to a much greater extent outside of them, meaning that we all need to reach to work across sectors. Every single one of us has a role to play in changing environments. Every single lived experience matters. Every disciplinary tool matters. Every action matters. The second part of our title is centering diverse voices. And my second issue is to talk about how we can center diverse community voices. And here I'm going to uplift community engaged approaches. So as you've heard throughout this presentation, it's through engagement, actual, authentic, real engagement with diverse communities that we hear, that we listen, that we understand, and that we partner. In almost every discipline, there's now a commitment to community engaged approaches. And these are defined, and here I'm paraphrasing from a paper by Cynthia Gordon da Cruz. They're defined as beneficial partnerships between organizations. So that could be a religious institution, a healthcare center, a university. We've seen examples of all of those. So a partnership between organizations and communities with the intent to collaboratively develop knowledge to address social issues that the community identifies. Now there's a lot to unpack there, but the critical word I think is partnership. And participatory engagement and practice is grounded in many core principles and core values. I'm going to just highlight a few, and these come from the work of scholars in community-based participatory research, including our CPH Dean Edith Parker, and from the work of community members like those that you have heard from today. Starting with some of the principles, community engaged work starts and builds on strengths and resources in communities. The usual approach is to start from deficits. So to consider what's wrong with this community. And we approach communities often with that mindset. But that question begins an othering process that impedes our ability to work together as partners. Every community has strengths. Every community has assets. We start together from those. This really requires a mind shift. And I remember my aha moment about a decade ago now, maybe two. Much of the work that I do is around adolescent and youth well-being in partnership with young people. And the general approach in that field is to consider youth at risk. So you sort of identify youth at risk and you work with youth at risk to create environments that enable them to succeed. But a youth scholar suggested that we flip the paradigm and consider all youth at promise. Can you imagine the world that we can create if we consider all youth at promise? If we consider everyone at promise? It fundamentally changes how we think about interventions, how we engage with each other, how we do this work. Community engaged approaches also, as a principle, develop equitable partnership where power is shared and social inequities are attended to. This is really a critical point because it means that everybody around the table is an expert and that titles don't confer more or less expertise. Each one of us has something to contribute to the understanding of the wider issue. Now, this may seem like a simple ask, but it really isn't, because our structures of education and economics and politics confer power on people and take away power from people. We, and I'm talking in the academy as educators, have been inculcated in this structure, whether we know it or not. So being willing to take off the expert hat and be an expert takes a lot of hard work. The most important value that I want to highlight in this community engaged work is non-othering. Othering, or seeing people as fundamentally different from ourselves in negative ways, I would posit is at the core of all the isms across the world. Racism, ableism, ageism, sexism, and all the rest of them, and is again embedded in our social structures. Othering begins a process of us and them, a process that divides. Othering never creates equitable opportunity for all and will never achieve our goals of equity and justice. I'll speak to one other principle, and that is dignity. And you've heard that term used throughout today, even though I didn't, again, that did not come up in the main points. I hold this term really close. I think it has a lot of potential to create authentic human connection. If one of our objectives is to leave every interaction with every human being in that interaction uplifted in terms of dignity, so that I walk away from any interaction, all of us walk away from any interaction feeling valued and feeling like we have committed to ensuring that the other person is valuable as well. What a world that creates. Seems simple, but takes hard work. Referring back again to the paper by Gordon de Cruz, they suggest 4 questions to guide our community engaged work for equity and justice. Are we collaboratively developing critically conscious knowledge? And I think critically conscious knowledge comes in many ways. And part of the problem is to get rid of what we are trained to consider as knowledge. The second question, are we authentically locating expertise? Are we centering community voices? The third question, are we conducting race or other axes of oppression conscious work? And the last, is our work grounded in an assets-based understanding of community? And I think those questions help us to work in a space of equity and justice. My final point may be the most important. I think the real work that we need to do to achieve health equity and social justice is to understand, acknowledge, and reverse the effects of the groundwater that we've been drinking. I understood this approach in a workshop that I took with the Racial Equity Institute, where they talk about the groundwater approach. And it's a story that goes like this. You have a house and some land and a pond on the land. You come out one day and you see one of your fish in the pond, belly up dead. At that point, you're asking some questions. Most of the questions are centered on the fish. What is wrong with this fish? This fish must have had a genetic makeup that wasn't a good makeup. The fish maybe was eating things in the pond that they weren't supposed to eat. It's all about the fish. The second day you come out and half of the fish in your pond are dead. Your questions fundamentally start to change. You're starting to think about what possibly might be in the water. The third day you come out, and it's not only the fish in your pond that are dead, but the fish in all the other ponds in your neighborhood. And here again, your questions are changing, and you're starting to think about the groundwater. What is in the groundwater? The work that we all need to do to understand, acknowledge, and reverse the effects of the groundwater is to start by understanding that we each embody all of the colonial, oppressive, patriarchal, capitalistic, social structures that have surrounded us from birth, and often before birth in terms of generational trauma. All that we hold inside ourselves and how it colors everything we say and do. That's hard work. But the vision of an equitable, just society is impossible without that work. The work is painful, it's constant, it's uncomfortable. But if we are each committed, if you are each committed to equity and justice, I invite you to do that work and to sit with discomfort. I invite you to be willing to question, to be vulnerable, to grow. It really is the only way that we can achieve the world that we want. Thank you.
Thank you, Rima. Absolutely. So I'm going to open it up now for any questions that our listening or viewing audience might have. So once again, for our listening audience using Zoom, we welcome your questions via the Q&A function. We do have a couple questions that I'm going to throw out to you from our audience. The question is, and it looks like it's open to any of you to respond to. That question is this: sometimes caregivers and their loved ones fundamentally differ on, for example, choosing comfort care over pursuing a miracle cure. How would you advise interpreters to approach these very charged conversations?
Maybe I'll start on that question, Valerie. Thank you. And it's an amazing question, just because I think a question like that could take up a whole conference as to how to work with interpreters, right? But I think the simple thing that I'll say is that as an interpreter, really my role, it starts and ends with that word, interpreter. I'm there to help them with that communication. Now, and to Pastor Joseph's point, there needs to be advocacy as well. And that's kind of a very gray area for interpreting in terms of the code of ethics. When is an interpreter really allowed to step out of those boundaries of interpreting and advocate? And the code of ethics in the world of interpreting really point to only one specific one specific factor that can let us do that, and that's if the patient's safety or health is at risk. Now, with that said, I think it's important for providers to kind of realize that, a Congolese family or a Spanish-speaking family from anywhere in any Spanish-speaking country they're thinking of comfort versus treatment and all of that will differ, not unlike any American family or any English-speaking family. And so keeping that in mind, that we don't need to reinvent the wheel as to how we're going to approach this family. We just need to be, to Mary's point, very culturally sensitive and understand that, because as providers, we think we're giving you these two options, and we feel it's an easy choice between comfort or not, forgetting that there's a religious background, a traditional background that really does not understand that end of life type of conversation maybe. And so really telling providers, once you hear what their answer is, don't try to push them to go the other way. Listen to why they're understanding that. And I think Mary is, to his point again, I don't know if the story that he told, what happened in this institution, because it sounds exactly like one that I was involved in, where I was called in, there was issues with the iPad and communication, and we were able to bring in an interpreter that was a refugee like this family, and was able to really communicate with them and get them to kind of have that connection with the team. And so then it wasn't so difficult now for providers to understand why the parents were so reluctant to provide this treatment for their family, right? So yeah, as an interpreter, all I can really say is, if you have, as a healthcare provider, if you have access to your interpreter and can do a little bit of, staffing or a conversation prior to you entering a room, that might help, it allows me as the interpreter to kind of provide a little bit of cultural background or religious background as to why you might be hearing certain answers from the family. But always remember that, I'm the bridge to that communication. And so as long as you're talking to them in an empathetic way and not necessarily telling them you have to decide, it's really talking to them like you would any other family. I just had a situation 2 days ago in one of our intensive care units where that's exactly what we were doing. And, the mom was very much like, how can I, how is God going to put me in this position to decide whether my daughter lives or dies? And that's kind of how her mind frame works. So then that allowed the doctors to kind of rephrase what they were trying to say, or really, circumvent that by talking about it in a maybe different way. And explaining that, we're not putting you in, hopefully we're not trying to put you in that position, but just want you to kind of understand where we're coming from. And so those charged conversations definitely require, again, obviously a bilingual staff member that has training in interpreting, because just if you had something like that happen with a cousin or a sister or a brother, you can imagine that the communication is going to break down quickly. And as an interpreter, I can really help. When we're interpreting, we're also we have to be storytellers. We have to, point at what this person is saying and take what this person is saying and really bring everybody together so that everybody in that room is understanding a common language and can really help provide the care that they want to provide, and not so much point fingers or judge, why aren't you, why don't you want this transplant for your child? This is obviously what they need. It's really understanding the different reasons why they're deciding that, and having culturally appropriate and, responsive caregivers that can diminish some of those cultural barriers, not take them away, because like you said, like Rima says, we're not trying to other, it frustrates me so much when people call me and say, this person doesn't understand anything I'm saying, like it's a problem. I've seen language listed as people's list of problems or diagnoses. And so that is, it's an easy answer for me to tell them, I'm here to help you break that barrier. Forget that they don't speak English, use me, and let's have that conversation.
Great. Anyone else want to respond? All right.
I also understand that we can try to put a lot of responsibility to interpreters, but as Adrian said, they are there actually to just help their communication work, like to be the bridge between the providers and the patients. And when we switch the responsibility for them to become also the advocate for the family, it's put them in a hard situation, and to balance whether they are doing the right thing or they need to hold off a little bit. That way it doesn't really violate the code of ethics. Now, what I was proposing before is that we can at least try to hire people, have a workforce that looks like the populations that we are helping, having a case worker who, case manager, who looks like that, the family that the care team is trying to help, will make a huge difference, because this case manager understands already the culture, understand the faith maybe that the family is practicing, and they know many things that can help at least this patient to come to a decision. But when we are trying to at least bring maybe interpreter using the iPads, and maybe the interpreter who connects with the family too, we are putting them in a situation where they have to do two things at the same time. I'm trying to interpret but also advocate. It's a lot that we are putting on interpreters. However, if we can have case managers, healthcare providers who look like the population that we are serving, these issues can be really addressed easily. And so we need to really reevaluate the workforce that we have in hospitals or any places where communities are seeking help.
Thank you.
Valerie, if I could just add there, and I know we want to go to another question, but what came out very clearly to me in what Adrian and Marius were saying, and even in the example of Pastor Lear when he went with one of his congregants and friends to the healthcare setting, is that language is not language. Language is culture. And I think that's a very important point that's come out, so that just having a person that speaks a language but doesn't understand the context of the culture may be more harm than good in a sense. So I think that's a really important point to bring out, and that was said so clearly in the stories.
Absolutely. Thank you. We're getting quite a few questions from our listening audience, and so I'm going to go to the next question. What is the role of the visiting nurses and or the Johnson County Public Health Department in these issues?
And I wish I could speak to that. All I can say is what I would want them to be able to do, but that's not for me to really chime in on it. I'll open the floor for anybody else that might have something to say about that, because that's a very important question.
I know that the Johnson County Health Department has a task force and a program that's really focused on trying to engage in participatory manner with the diverse communities in Iowa City. I probably should know more about that, but I don't. But I do know that there are efforts that are being made in the Johnson County Health Department.
I should probably clarify that though I work in the College of Nursing, I am not a nurse. So I also cannot answer that question. But perhaps any of our listeners out there who are nurses or served as visiting nurses, if you feel like you want to respond to it, we're more than happy to maybe have you share something on the chat, and I can certainly relay that to our audience. Let's go to the next question then from our audience. This person wrote, from my perspective, it seems like accessing a health insurance is a challenging journey for refugees. Am I correct? If so, what kind of support is available to help newly located populations from abroad in Iowa City to go through this administrative process?
I would like to just begin by saying that accessing health insurance is a challenge for me. I have fought health insurance in the marketplace and trying to follow everything that's happening for years. And it's bewildering. So if there is an advocacy group out there that helps people with health insurance, I need to go, not just at-risk populations.
Absolutely.
One thing that, and I'm not familiar with, any resource like that, which would be wonderful in the community, but I can tell you that, well, at least at UIHC, we do have a team of social workers that are specifically tasked to help with healthcare benefits. And so these are called healthcare benefits. It's the healthcare benefits assistance program. And so what those social workers do is once the patient is, registered or in the clinics, they can meet with them and kind of go through some questions to see what they qualify for, if anything, in terms of insurances, try to guide them as to how that, how to get that done. But like, to Joseph's point, English speaking educated people have very much difficult time understanding this convoluted system of healthcare. So, you compound that with language, compound that with no access to this. We can give people the name of the insurance company and how to call them. And maybe there's a Spanish or a French option, but then they're being asked different questions about, whether it's their living situation or their health or things like that, and that gets lost. And so many times we're not able to bridge that gap of, here's a great resource. To Marius's point, we can translate everything, but if we don't have ways to connect them to those organizations, or if those organizations don't count with people that can communicate effectively, then they're coming back to us worse than when we sent them, with higher bills and everything like that because of it. But there are ways in the hospital to kind of get that done, at least to help guide them to those resources when they qualify for them.
I'll add a little bit here too as well. Yes, I think you are correct. I would agree that you are correct that health insurance is a major barrier. There are, as Adrian has pointed to, there are some programs that support refugees as they come in with health insurance. They're usually shorter term, etc. They're also very hard to understand. So the Congolese Health Partnership has actually done an amazing job at trying to connect the Congolese community with with the providers in insurance, in WIC, etc. And by actually bringing those into the community rather than the opposite way. So having just an open conversation, as sort of like a town hall where the Congolese community came, and there were providers from the insurance agencies, there was providers from WIC, and it was amazing to see that relatively small step was able to break down so many barriers and understanding, because the people that are coming from insurance and WIC know all of the little details of what's possible, and they can start, and the community is sharing their really struggles and their problems, and the stories start to be heard, and some solutions start to be shared. So for example, the Congolese Health Partnership had somebody from WIC come in, and WIC is very complicated, and what you can qualify for WIC depends on, whether you're pregnant or not, how many kids you have, what age the kids. I mean, there's so many complicated aspects of that. And so the community was sharing how difficult it is to go to Walmart, go down the aisles that say WIC on them, right? So you think you're doing absolutely the right thing, and you get to the checkout counter and they tell you you're not eligible for these things that you just picked out, right? I mean, it's so frustrating. I can see that frustration. And the WIC person had two solutions. She said, one, I am willing to meet you at these places. Like we can walk around together and talk about these struggles. She also said there is an app that has you in it, basically, and you can sort of point the app to a particular thing that you want, and it will tell you if you're eligible for this much or this much, right? So there are solutions there, but the communication's not there. And so often it's not these very complicated, expensive solutions that we need. It's connecting people together in conversation.
Thank you. I'm going to go to another question from our listening audience. How can I, as a white person, know that I am doing authentic intersectional advocacy work and not white saviorism?
I can start with that, but I think many could. I think it's a mindset in how I perceive it, and the mindset is, I'm not coming to solve a problem. I'm coming to get to know you, to work together, to listen, and to understand that there was another question about expertise. I think everybody has expertise, and I've said it, or nobody does, right? I don't come into a community as an expert, because in fact, most often, I don't know anything about that community. I know quite a bit about the community that I was born and raised in, the culture that I was born and raised in. I can tell you something about that, but even those, right? None of our cultures or communities are monolithic. They're all so not monolithic. So we know very little, in fact. we do know strategies and tools that might work, but they may not work in that community. So really, it is that everybody around the table has the solution when put together, and that lived experience is one of the best aspects of expertise. That lived experience is really important. So for me, saviorism is a mindset that I have the tools that are going to help. And in working together in in a common humanity, I just start from, I want to get to know you.
Thank you. Another question from our listening audience.
Valerie, sorry to interrupt. Do you mind if I just say one more thing about that, Rima's point?
Oh, please, go ahead.
Thank you, Valerie. Thank you. And really what I wanted to say is that in order for you to be kind of authentic and really avoid that idea of white saviorism, is ultimately we have to basically from the beginning ask from the people that we're trying to advocate for what in their mind what it is that they need from us. And so a quick example about that, more recently I did some work with the Center for Disabilities and Development, and they were to kind of what the Congolese Health Partnership did. They were doing webinars for families that had special needs children for various different health needs that were transitioning from early age and middle school age to adulthood and post-secondary education. And so they brought in experts from waivers programs, DHS, all kinds of organizations that came and presented to these families. Now, I was involved because they had a good group of just Spanish-speaking families that wanted to participate, and we needed to figure out how to make that happen. Now, we provided some of this training without really taking into account that it's like, to Rima's point, it's what works for one family or one person is not necessarily the way you want to communicate it to another. So we, early on, the leaders in that group kind of asked, we got together with these mothers, brought them in on a conference call and video, and kind of asked them from the beginning, what do you think you need from us? If we give you these webinars all in Spanish, is that what you need? Or, is there other trainings or other things that you would like to see? And, we heard from them what they want, and now we're taking that back and we're working on how to advocate for those things. So I think kind of to my point is just, if it's just asking, like Rima said, not coming with the idea that, yeah, I'm here to save you guys, I'm here to provide all this education. It's really, here's what I can do, but what do you need from me? And then work off of their needs before we kind of move forward and spend all kinds of resources on something that at the end of the day is not going to be a solution for them.
Thank you. We're getting pretty close to our time, but I'm going to try to get in as many of our listening viewers' questions as I can. But one thing we do want to get to is can each of you or any one of you suggest how students or community members can get involved to work towards equity?
So I'd say that there's a lot of opportunity. Marius, did you want to take that?
So with Congolese Health Partnership, we do have medical students working, participating in the board to help make sure that at least when there is a message, they can help with getting it out, sharing. They can create these videos to just be there as part of the solution. And with the outreach, maybe when we are back to normal, they are able to come in, and when we are going to see these communities, they can be able to come in, present, and ask these questions. How can I be helpful? How can I partner with you so you can at least achieve these health goals, or all these goals that you are trying to achieve to have a better health? So there's many opportunities. They have to be involved in organizations that are out there doing some work already, and just join and reach out to the community, and they'll be able to help by partnership, by making a partnership with the community itself.
I would agree with what Marius said. I think there's lots of opportunities, and I think different students or different community members come with a with a desire to advance health equity, but they may also have another issue that's really important to them, whether that's, mental health or domestic violence or, reproductive health. And so I think there are many organizations in our communities that serve, or also around, across population groups, differently abled persons, or there's many organizations in our community that are actually providing amazing support to our diverse communities, and to reach out and say that you're interested and want to support in many ways. They likely have a lot of opportunities. I will say it's time, right? It's time and it's vulnerability. And I think the other thing that I heard very clearly, in our discussion, is this is not something that happens fast. It's something, so trust takes time to build. Listening takes time. It's time that's, in my opinion, so well invested, because it makes us all grow, and it makes our communities so much more compassionate. So I think the time is very important, but I think we need to go into it acknowledging that it takes time. At the university, there are also various, centers that are focusing on health equity. We have a space called the Health Equity Advancement Lab at the College of Public Health. That is a place that students, faculty, and staff come together to just talk about these issues. Because one thing that we found is, although we sort of know about inequities, we rarely have the chance to this is really hard work, and what have people tried, and what should we do? All of that really deep discussion that needs to happen, both the inside work and the outside work. So that's a space where we do that. But I think there are many opportunities for people to do this work.
Thank you. We are about 4 minutes left in our time. And for our listening audience, I'm sorry we weren't able to get to all of your questions, but we'll hopefully try to save some of those questions and maybe be able to respond in some other format. What I'd like to do is end with this question. Clearly, based off of the things that you've all shared, in order to achieve health equity, we have to unpack the complex, interrelated set of individual, provider, health system, societal, and environmental factors to change. What should or can be done to address health equity gaps, and how do we get the people who you serve to be at the policy table in order that their narrative gets out there so people understand?
It cut off a little bit, Valerie. Can you repeat the final part, the whole question?
Yes. How do we get, if you could wave your magic wand, what would you change? What do we need to do to help bring the populations that you serve, as well as minoritized populations, persons from lower socioeconomic status, immigrant, refugees, all the marginalized populations that we've been encompassing today. How do we get them to the table, or how do we get their leadership to the table so that way they are in a position to also have their voice be known in terms of setting policy and making decisions about how to engage with their respective communities?
I have something I would like to say to that point, Valerie, and that would be amazing, right? If I had my little magic wand, and I would change two things. One thing that comes up very often, and I love when I hear this from staff members and patients, I wish we could clone Adrian. I wish we could send Adrian to all the different places that need it at the exact same time. And so if I had a magic wand, I would do that. I would clone myself and all my team members and just make sure that every single patient that walks through our doors has that interpreter, has that advocate at the bedside, literally for every communication. There shouldn't be any communication that happens without an interpreter for people that need an interpreter. And so that would be amazing to see, because that would not only break down the language barrier, it would hopefully break down some of that cultural barrier as well. It would help our families that are hospitalized not feel that great sense of isolation when they're here. we might get requested for an inpatient a few times a week. And you have to, we all know that there's more communication happening with this person more than once or twice a week. And so that would do a lot to help just bring everybody to the table. And something else that I would do, and this is something we're kind of working towards as well, is bringing these community members to participate in different committees. And maybe it's not, a high level policy committee, but it's a patient advocacy group, or, the family councils that many hospitals like ours have. It's really bringing those community members to participate in those conversations so that their voices are heard, so that their concerns are heard and they can be addressed. Because, kind of like the old saying goes, we can't fix what we don't know. I think in this world, we know a lot of these issues, and we just need, like to Pastor Joseph's point, hear from them directly, hear from the community members what it is that we're lacking and what are the priorities, so that we can hopefully redirect some of our resources and time to fixing all of those, instead of trying to come up with this grand solution of, a blankets or umbrella solution for everybody. And so I think it's really just inviting these community members to join the table and helping them, with that, because many times these have application processes and things like that. And it's time consuming. It's hard to tell a immigrant parent of 4 kids who works 2 jobs to join a conversation like that, but really at least giving them that opportunity.
Great.
Valerie, I know we're out of time, but I just wanted to make one point about language. In this sense, not language that's different than English, but actually English language. To also point out the sort of the groundwater that we live in. I think language does matter, and I'm going to uplift something you said, Valerie, with deep respect. But when we say marginalized communities, to me, that is in some ways beginning the othering process, as opposed to communities that are experiencing marginalization, because that removes the othering from the community to the environment in which they're living. And so I think this is part of the work that we each have to do every day, to understand that the language that we're using is in itself oppressive and inequitous and unjust. So I'll just make that point. I know we're out of time, but thank you for this opportunity.
Absolutely. Well, I want to thank our panelists, Patrick Taggart from Proteus Incorporated, the Reverend Dr. Joseph Lear, lead pastor of Resurrection Assembly of God, Adrian Silva from UIHC Interpretation and Translation Services, Dr. Marius Balola, board member of the Congolese Health Partnership, and Dr. Rima Afifi from the University of Iowa College of Public Health. I also want to give a special thank you to Dr. So-King Oh, Director of Global Health Studies Program at the University of Iowa College of Liberal Arts and Sciences, and her team, including our tech guru, Nick Arp, Director of Communications in the UI College of Liberal Arts and Sciences. If anyone in the audience would like to learn more about this topic or connect with any of today's panelists, you can contact Dr. So-King Oh from the UI Global Health Studies Program. A special thank you to the UI Department of Anthropology, UI Carver College of Medicine, UI College of Public Health, UI Geographical and Sustainability Sciences, and the UI College of Nursing. Before we leave, I also wanted to mention that the University of Iowa will be hosting its annual Culturally Responsive Healthcare in Iowa Conference on Thursday, June 3rd from 8 to 2 p.m. This will be a virtual conference, and the keynote speakers will be addressing a couple of items. Number one, the importance of diversity, equity, and inclusion work in healthcare, and racial disparities in COVID-19. And you can get more information about this virtual conference by going to the Carver College of Medicine website. Thank you to our audience as well for joining us today. We hope this session has provided you with more information, but also fuel to make equity a priority. I'm Valerie Gar from the University of Iowa College of Nursing, and on behalf of the College of Liberal Arts and Sciences 2021 Theme Year Initiative of Pursuing Racial Justice at the University of Iowa, we thank you again for joining us. Have a great afternoon.
Thank you. Thank you.
Thanks all.
Thank you.
Nick, thank you for answering that question about the medals.
Yeah, I didn't know if you would see it. So.
I saw it kind of towards the end there, but that was Awesome. That was great. Thank you guys. Thank you for the invitation again, Soken and Nick, for all your help with this. That was I'm excited to kind of, I'm already getting some emails with some questions and feedback. So this is great.
Oh, that's great. Yeah, I told somebody who asked specifically, how do I do what that guy's doing? And so I sent them your way.
Oh, very good. Very good. Thank you, Nick. You guys have a good rest of your day.
You too.
Thanks, Adrian.
So King,
Yes.
I think that went well.
Yes, I think
Valerie?
it did very well. Thank you
Valerie, you did a
so
great
much.
job.
Well, thank you. For my Zoom web, it was like even right now, it's circling, and so there were moments where I didn't hear anybody speaking at all, so I didn't know. So I just didn't say anything. I just thought, well, it'll come back. So it's just kind of acting weird right now.
Well, we had, there were about 50 people on YouTube at its peak, and we had at our peak here about 130.
Are we still live? Are we still recording? It says live recording.
Oh, yeah, sorry.
You could edit all that out, though, can't you?
Yeah, we'll just edit all that out. Anyway, I have to run anyway, but congratulations on a great event, you guys, and I will catch up with you via email with video links and stuff like that.
Thank you, guys.
That would be great. Thank you, So King, for inviting me to be part of this. I enjoyed it.